All right, why don't we get started? Welcome, everyone. Thanks for joining again, or if this is your first time. This is our hope to be a series of webinars really focused for certified lymphedema therapists and giving you a variety of different topics. Last time we just gave you a general overview of the Boston Lymphatic Center. And today it's great to welcome Emily Muller, who's one of our lead certified lymphedema therapists, and Elizabeth Tillotson, who is our surgical nurse practitioner. Together, they have started a new program, which they'll walk you through a little bit of today, using a new advanced imaging technique to really guide manual lymphatic drainage and see if we can optimize lymphatic drainage for certain patients, particularly if it's in areas that we're less accustomed to using MLD in. So I will turn it over to them, and we'll take some questions at the end as well. Thanks again for joining.
Awesome. Thanks, Brett. Again, I'm Elizabeth Tillotson, or Tilly. I am a nurse practitioner that works specifically with lymphatic patients. So just quick introduction of myself and Emily.
I'm Emily Muller. I'm a PT, but I'm also a CLT, and I exclusively right now work with patients with lymphatic disorders as well. So
awesome. So indocyanine green is a dye that we can use to map all sorts of different parts of the body. So historically, this dye was used actually to do eye exams. It can be used intravascularly to look at perfusion of different areas of the body. So in plastic surgery, we actually use it intravenously to look at the viability of free flaps after we do reconstructions. But if you inject this dye right into the skin, you can actually use it to map the superficial lymphatic system. So these injections are done intradermally, so right into the skin, not below into the sub-Q tissue. Definitely better uptake when you go right into the skin. And we do this for all of our patients here in the center to take a peek at what their lymphatics look like. The way that it works is it binds to albumin, and then it's taken up in the lymphatic system, and it's actually taken up immediately, which is pretty cool. After we inject, we can start seeing the lymphatic system seconds later, which is pretty awesome. We use it to diagnose and to stage lymphedema, and it's also used in the OR for sentinel node biopsies as well as the other indications I told you about. You can on the right side there, that's a quick picture of an indocyanine green, but we're going to go deeper into that. So we can advance the slide.
all right.
Thank you. Okay, so ICG findings when we apply them to lymphatic patients or patients with lymphedema. So a normal channel is going to look like a really well organized linear channel, meaning it's going to look like a straight line. The next stage of, as we go along the grading system, we call it a splash pattern. A splash pattern is quite similar to a linear pattern, but it's when the channel starts to lose a little bit of organization or starts to look a little bit wider or a little bit fuzzier. The next pattern that we see is really once the lymphatics start to collateralize, or if they reach a blockage and the dye will come to the superficial skin level and try to find other ways through to drain the extremity or the part of the body that we're focusing on. That's called a stardust pattern. And then really the worst or the most congested tissues that we see, we describe as a diffuse pattern, which is really just a super bright collection of dye in the skin that I'll show you examples and photos in the next slide. So at the Boston Lymphatic Center, we really don't use a number grading system. We use our descriptions of ICG more than we use an actual stage 0, 1, or 0 through 5 like this slide. But this is a good slide to sort of walk you through what those descriptions I just went over with. So if we start on the left side, stage 0, that's a healthy extremity. So those channels are all linear, really well organized, thin channels and very discrete channels. You can see traveling right up to the antecubital crease there. Stage 1, so a little bit hard to differentiate from the prior slide until, of course, you get to that area of that looks like almost like a cloud pattern. But if you start looking at those linear channels as they approach that area of blockage, they do start to thicken a little bit. Again, a little tricky to see on that slide. But then they reach an area of what we would call stardust, which almost looks like a night sky. That's why it's called stardust. And that's an area of collateralization that is not quite as congested as, say, that stage 4, where you can see it's really hyper, really bright light. You can see, especially like the level of the wrist, that's probably the most bright, and we call that the diffuse pattern. So again, it goes linear, splash, then stardust, then diffuse. Stage 5 there is really 0 dye is traveling at all, and that's the most advanced that we would see, ironically. So although diffuse is the highest level that we see on ICG, when the dye doesn't travel at all, then there's really not much that we can do in that extremity as it pertains to ICG-guided MLD. We can go to the next slide. All right, so this is a video actually showing an area of stardust, which is connected through the antecubital crease by a linear channel. So this is the left proximal forearm. This is what we call, again, that stardust pattern. And then as we come across the antecube, we have this nice linear channel, and then into another area of stardust. This is just a good video to see the difference in the ICG readings. And here we're actually marking out that linear channel, because one of the procedures that we can offer patients, if they show these patterns, is we can go in and target those areas to do a bypass. If we can see exactly where the channel was blocked, but that is not what we're talking about today. We're talking about MLD today. So next slide. Quickly wanted to touch on some of the research that we're doing at Beth Israel. So breast cancer related lymphedema is the most prevalent type of lymphedema in the country. So a lot of you likely, when you're seeing your patients, are dealing with patients with breast cancer related lymphedema. One question that we're really trying to figure out, and ICG is critical to this, is why is it that patients that have had the same surgery and have the same risk factors for lymphedema, about 33 to 35% with those high risk factors, which are an axillary lymph node dissection followed by a regional lymph node radiation, go on to get lymphedema, while about 60 to 65% do not. We're working to figure this out, and we don't think it is exactly correlated to the MS pathway, but there is a pathway that follows the cephalic vein that is described as the SAPI pathway, or the MS pathway. And we're finding that about 78% of patients have it, and about 68% of those patients, it goes to their deltopec groove rather than their axilla, which we believe is potentially somewhat protective against lymphedema. So here you can see how we use ICG to find that pathway. So A is just showing you where the cephalic vein is. B is, again, an injection into the skin and then lighting up the lymphatic system that travels right along with that cephalic vein. You can advance the slide. And so some patients have what we call a long bundle, meaning that that quote protective pathway, or that MS pathway, communicates with their hand. And others have something called a short bundle, which means they don't have a connection from their distal extremity to their proximal extremity. And basically what we're trying to do is correlate these ICG findings with why do or do not patients develop lymphedema after the exact same surgery and the exact same treatment. So it's just a cool application of ICG that I wanted to share with you guys. And then we can advance the slide again. This is oh my gosh, what are those things called? A QR code, I believe, that you can scan. If you want to watch a video of us actually doing an ICG in real time for a patient, it's the whole start to finish experience of what a patient goes through when they come in to be imaged. So cool for everyone to see, especially CLTs, if you're considering, getting involved with using this imaging to guide your MLD. It's good to be able to tell your patients what to expect. So here's a video of us actually doing it. We're not going to do the whole video, but more than welcome to scan if you're interested to watch what the experience is like in the clinic. Next slide. Yeah, here we go.
Okay, so this is where I'll take over. So I just put this slide up because we are all kind of taught similar pathways of drainage, these presumed pathways during our lymphatic certification courses. If somebody has left upper extremity breast cancer related lymphedema, we're kind of taught to administer our MLD and kind of clear the pathways in certain directions, oftentimes going to the contralateral axilla and the ipsilateral inguinal nodes to kind of redirect or kind of encourage the drainage pathway to these areas. And why ICG-guided MLD is really cool is because we're finding that not everyone acts this way. We presume that these pathways are available, and sometimes maybe yes, other times maybe no. So if we can guide the patient's manual lymphatic drainage strokes and kind of clearance techniques to their personalized anatomy, that's really the goal here, and see if we can kind of optimize and improve their flow. So Tilly and I and our research fellow, Rosie, were lucky enough to travel to Sydney, Australia, June of last year to meet with the Macquarie University ALERT team. It's Dr. Louise Kohlmeyer and her team who really have pioneered this technique for applying this ICG kind of diagnostic tool into direct treatment application for a patient. And they were very gracious with us and walked us through every step of the way and helped us to kind of start our program, our humble little program. We're kind of ramping up slowly. We'd love to be as robust and as comprehensive as they are now, but we're kind of starting here a little bit slower in our center. But we really owe a lot of credit to them, to their guidance and mentorship. So shout out to them. So the benefits of ICG-guided MLD, I kind of touched on this a little bit, but I think one of the biggest things is real-time visualization of this patient's anatomy and how their drainage pathways work. Not only is it helpful for you as a therapist to watch this and you're like, it's kind of eye-opening and really cool for you, it's very validating and very important for the patients to see their own anatomy and their own kind of areas of dermal backflow and things like that. It's very, very enlightening for the patients as well. So areas of dermal backflow, that's kind of where the kind of areas of disease are most prevalent. So oftentimes your patient will be like, oh, I really see or feel that this area right here bugs me the most. It feels where most of everything is. And 9 times out of 10, when you do their ICG-guided MLD or just their ICG, that directly correlates to a T where their dermal backflow is showing up and lighting up on the screen. So it's very validating for those patients to see that. And then for you as a therapist, it's great to see where their linear channels exist on this patient. If there are any, hopefully there are some, and that's kind of your highway. So you can kind of direct your flow or direct your drainage pathways and your manual lymphatic strokes towards these kind of highways to kind of efficiently drain the limb in question or the body part in question. And then you can kind of personalize the amount of pressure or the direction of manual lymphatic drainage towards their specific anatomy. Amount of pressure, I think, is important because I think, you know, personally, when I was taught MLD, I was always erring on the side of really light pressure. I wasn't giving it a whole lot of pressure, but knowing now what I know, a lot of these areas of dermal backflow in particular require a little bit more downward pressure while you're mobilizing the tissue to get the fluid to move. Also, you can find some pretty unique pathways in patients that maybe you weren't expecting that you can utilize and help this patient drain that area more effectively. And interesting things like valve dysfunction, I don't know the numbers on that, but we see a lot of primary lymphedema have some of them have some valve dysfunction. And that would be basically retrograde flow backwards of what you would expect. Can I push the fluid backwards up the chain rather than kind of the direction that you would expect it to go? And that would have implications for your MLD and your management as well. Again, if we can optimize the manual lymphatic drainage, can we optimize the flow and improve the patient's symptoms? That's what it's all about. Here is a video of what the ICG looks like in real time. Kind of right after the injections. This is probably, to be fair, a few minutes after the injections because we see quite a bit of uptake of the dye. But just a little background, this patient has known lymphedema, a patient who's actually had a debulking procedure with us. He was nice enough to let us video him one day. So this is his leg. You'll see areas of stardust here. There was kind of some more diffuse stuff kind of coming up the leg. A little more stardust, and then it's going to scan back down as well. But again, these areas of dermal backflow are areas where these linear channels are being not abandoned, but the fluid is trying to find another way out, and it's dispersing into the tissues beneath the surface of the skin, trying to find an alternate escape route. So that's without a whole lot of manipulation manually. That's like after injections, the system, as Tilly said, picks up the dye pretty immediately. And then this next slide is Tilly's in the room. She's got the camera there. There's the patient, obviously, and then I'm sitting with the patient applying some MLD techniques. And you'll see we'll scan back and forth from what the patient can see on the screen, which is in front of him. I've got a secondary screen behind his shoulder, so that's why I look like I'm looking off into the distance. But here we go. So he's watching kind of beyond me. I'm watching behind him. And then Tilly's got the camera, the infrared camera, to be able to visualize what's going on. And I'll show you another video of the ICG moving. This is more of our wide view, or just to give you more of the patient experience side of things. At the very end, you can see I'm pointing to something. In the next video, you'll see a little linear channel that's connecting some areas of dermal backflow for this patient. So here we go. Tilly, were you going to say something? I'm sorry.
Yeah, no, that's perfect. I was just sort of going to reiterate how awesome it is for patients to actually see the dye travel in their extremity. It's such a powerful moment for people. And I think that sometimes that is the biggest takeaway is sort of seeing this stuff in real time, just like you mentioned.
Yeah. All right. So you can obviously see my hand. I'm manipulating the tissue, and you can see that area of dermal backflow being mobilized, kind of pushed through the tissues. And then you can see kind of near my index finger now, that's that linear channel. It's a tiny one, but it exists there. And so presumably for this patient, we would kind of encourage him to, utilize these manual lymphatic drainage pathways via any linear channels that we can find. Also, we know that areas of dermal backflow, these giant blobs on the screen, we want to redirect them too. If we have a linear channel to direct that towards, we're going to use that. If not, we can actually see movements of the dermal backflow in one kind of general direction. We can push towards that, and we find that there's no redirecting. We can't go and push that fluid with any amount of pressure, not that we want to go deep, but we can't push it a way that it's not really draining towards. We can't redirect flow. And I think that was an important takeaway for me with all of this, is just knowing that there is a pathway that it wants to follow, and we kind of have to optimize that and make that efficient rather than trying to redirect to another place. At the end of the ICG session, we're doing the injections, and then we're mobilizing the fluid, and then we can present this to the patient. We send it out to them in the mail. We give them a mapping of their personalized pathway, drainage pathway. We give them a kind of what Tilly's report exactly says in her note. So kind of medically speaking, what the ICG report came up with, some recommendations by the therapist, what position might be better to be in, or how much pressure to use, or different takeaways that way. And then what I didn't include on this slide and is included in their report that they will get mailed to them is a step-by-step instructions on how to do their warm-up moves, or their, I think somebody said a Vodder trained CLT recently told me, uncorking, that kind of those clearance techniques before you actually work on the limb in question or the body part in question. And then going on to address the actual body part and utilizing those pathways that we identified. These are just a couple of quick examples of the mappings that we draw. These are a far cry from the very detailed and beautiful mappings that the folks at the alert team provide their patients, but we're trying. And it gives a good sense for the patient where their areas of dermal backflow are, where their linear channels are, what direction they're trying to aim for, their targets, kind of which lymph nodes we think that might be available to them to kind of get that fluid to drain towards. So those are some upper extremities. That's the posterior view and the anterior view. So we're looking at everything. And then we are doing a lot of breast ICG-guided MLDs. particularly because a lot of these patients don't have some certain surgical options to relieve or alleviate their symptoms. So we want to offer them some more fine-tuned conservative management tools for their toolbox. So I put this patient mapping up there also because it shows a couple of different things. This patient is a post-mastectomy, very heavy radiation post-mastectomy, a lot of scar tissue. She is very symptomatic, but it ultimately came to be we couldn't find a lot of dermal backflow or disease. So that's one thing. So a lot of scar tissue symptoms probably, but interestingly that she drained to her contralateral axilla beautifully, like right off the bat, actually with probably very minimal manipulation on my part of the dye. And she was in supine. She wasn't even like side lying on that side. Gravity didn't take it there. It just really got picked up pretty swiftly by the system. And she had two beautiful linear channels, one that went right above her nipple and one that went right below, and they both targeted towards that contralateral axilla, which was very cool. We're seeing a lot of that. And outcomes, and I just kind of wanted to touch on this too. Again, we're very new at this, and we're doing a kind of slow ramp up to see kind of feasibility. Can we start doing this on more people? Of course, that's our goal. We want to be able to do this and offer this for more people. But right now we're doing a lot of these breast edema patients. And so outcomes are very tricky with that population. We don't have a lot of objective measures we can use to track these patients. We are doing we have a baseline MRI for these breast edema patients, so that's helpful. You know, down the road, we may be imaging them to see if we've improved their symptoms, if they've kept up with this and done it regularly. We're using a lot of symptomatic questionnaires. So we use the symptom intensity and disability scale for lymphedema for the trunk for a lot of these patients. But I think the more limbs we end up doing, the more hard data we'll have, and I think that will be helpful as well going forward. And then that kind of wraps up most of, I think, what we're talking about. But I also wanted to do a shameless plug here. We're going to be offering the Boston Lymphatic Symposium, November of this year coming up, and it's actually going to be specifically dedicated to education and kind of support for lymphedema therapists. And we're going to be having Dr. Louise Kohlmeyer from Macquarie University be our one of our keynote speakers. So it's very exciting for us, and hopefully something that you all as lymphedema therapists might be interested in attending. So more to come on that. I'm sure there'll be a lot of advertising and emails sent out, but I just wanted everyone to know that we're in the works and planning it. And I think that's it. Yeah. Does anyone have any questions? I think you can like raise your hand, or you can put something in the chat.
Yeah, I think if you raise your hand, we could take you off mute. Are there any questions? Maybe while other people are thinking, I'll just ask a quick question. Emily, how has your experience been so far in terms of how surprised have you been on some of these where you would say, oh, I would have done MLD this way, but now that I have a little bit of a roadmap, I'm shocked, but I'm actually going to take it this way.
Yeah, I think fairly consistently we're finding that these breast lymphedema patients, and we're injecting along their IMF, they're just below the breast if they have one, but kind of low in their chest wall or mid chest wall. And we're seeing that not many of these people drain distally or inferiorly towards their inguinal nodes. We have had a handful of them go kind of midway through, and we're thinking that maybe they're getting some connections to the deeper system through their ribs, but we haven't seen anyone go all the way down to that inguinal lymph node area. And that's been surprising to me because that was like one of the hallmarks of what I learned. I should say that there's a caveat here. We're looking at the superficial system only. So can we say that it doesn't drain down that way? Absolutely no. But so I don't want to discount the benefits of maybe doing that for some people, but we're just not seeing it superficially.
And Allison Mason asks, who is performing the injection? Tilly, I know who does it here. Do you want to talk about, what you've heard from around the country? Who else does it?
Yeah, so injections do need to be done by, at least at Beth Israel, either a nurse or a nurse practitioner or an MD. So for us, it's myself. I do all the injections. And then actually we're writing a protocol for nursing to be able to do injections as well. So it's really just the same as like a TB placement. It's an intradermal injection. In Australia, they had the MDs doing the injections, because there it's mostly run by docs and then the CLTs. So they would do the injections and then leave the room entirely. And actually the CLTs would manipulate the camera and run the MLD. That's how we're organized. I do think in the States, you'd have to have a nursing license to do an intradermal injection. So either a nurse or a doctor.
Great. And then Rachel asked, how do we refer? So Rachel, there, I could put in the chat our phone number, and then the admin can, our great admin can help coordinate who would be the most appropriate person to see. Generally, they see either myself or our nurse practitioner, Betsy Rose, first, and then we kind of help guide them to, would something like this program be helpful for them, or optimization with their local therapist, or referral to Dr. Singhal, our surgeon, and we kind of go through that and we kind of help guide them through our center. Though if you had a specific request for this, we could certainly in time try to develop that more clear, straight referrals for ICG MLD. So I'll put the number here, and there's also just if you Google BIDMC Lymphatic Center, it has our website and all our contact information. So if there are no other questions, we will end now, and our plan is to have another webinar in the fall. Let everyone kind of take a break through the summer, given a lot of people are away at times. And then Emily had the thought of maybe focusing a little bit on surveillance and measurements and how to approach that from a CLT perspective. And then we'll start mixing it up thereafter with more advanced, maybe lymphatic imaging, maybe a surgical talk, maybe some external people like wound care, and how to manage infections from a therapy standpoint. So again, thanks for joining. Have a great rest of the day and good summer, and you'll hear from us probably towards the end of the summer. Thanks, Tilly and Emily, for joining as well.
Thank you.
Awesome. Thank you.